Yeah, good evening, everyone. This is the Rota complication. I would not say it's a worst complication. Casey is a 65 years old male who's a non-diabetic, non-hypertensive, non-smoker. Got admitted at outside hospital with infual STEMI, underwent primary PCA to RCA. And the angiogram revealed 100% occluded RCA and heavily calcified circumflex in the LAD. And he underwent PCI to RCA with 2 DES outside and then referred to our hospital for further revasc. ECG serial changes of infual MI, LV 50%, infual hypokinesia. Hemogram and other biochemistry parameters were normal. And coming to the angiogram, this RCA2 stents were patent. And there was a diffuse long segment proximal to mid-LAD heavily calcified lesion. And there's one large diagonal arising from the disease segment, also very heavily calcified. Circumflex had moderate disease with some calcium in the AV groove. So with a long segment proximal to mid-LAD disease and also diagonal disease and the circumflex, we had two options, either to go for the graft to LAD, diagonal and the OM, or go for the PCI with Rota ablation under imaging guidance. After heart team discussion, patient opted for PCI with Rota ablation under imaging guidance.
Your EKG changes were, this is a
he underwent primary PCA stable? Outside, the index hospitalization outside, underwent primary PCA to RCA, then subsequently referred to us for the further revasc, complete revasc.
Okay, go ahead.
And decided to go for the Rota PCI with the imaging guidance, but over the workhorse wire, the OCT catheter was not able to cross because of heavy calcium and the tortuosity and tight lesion. Then
and this is a 125 bar or a 1.5?
This is 1.5 bar.
1.5, okay.
This is able to cross with the microcatheter, field of fine cross, and then it's 1.5 bar, ablating the proximal to mid segment, and there was a little bit of resistance in the mid segment. With the 4 to 5 passes, we were able to cross the LAD lesion, and LAD looks quite okay. And then did the OCT. And OCT revealed a diffuse calcium right from the distal mid and proximal LAD segment. There were Rota cuts, and there was at places it was 270-degree arc of calcium, other places it was close to 360-degree, and there was a calcium nodule also at the mid LAD. And I'll show you the snapshots. These are Rota cuts. The calcium, this is deep calcium nodule, Rota cuts. This was the LAD. And after LAD, did Rota ablation for the diagonal. This again with the field of fine cross, and then it's 125 bar. For diagonal, it's a 125 bar. And it's a good Rota ablation. It's a smooth Rota ablation for the diagonal. And post Rota ablation of the diagonal, we got a decent opening of the diagonal ostium, which was very critical to begin with. And because there was diffuse disease in the diagonal, so decided to go for the provisional approach for the diagonal. And this is the NC balloon dilatation with a 275 at high pressure, 16, 18, 20 atmosphere in the distal LAD, and with a 3 millimeter NC balloon in the proximal LAD at high pressures, 18, 20, 24 atmosphere. After the optimal preparation of the bed, and then went ahead with the stenting. Yeah. This is 3 into 32 DS in the mid-distal LAD, and then 3.5 into 38 in the prox LAD, overlapping with the previous stent.
Your diagonal is the only branch all the anterolateral wall has.
Kept it provisional, yes.
So you stented it with protection with the wire, or you decided to do provisional, no?
Yeah, I decided to go for provisional, yes.
Yeah, keep going.
And this is 3.538 DS, overlapping with the previous stent at 12 atmosphere. And the diagonal looks like in the right panel, flowing well, and there is no significant compromise in the ostium of the diagonal. We're quite okay. And this is the NC balloon post-dilatation with 3 millimeter at 16, 18 atmosphere in the distal and mid segment, and with the 3.5 NC at 18 to 22 atmosphere in the proximal LAD segment. And this looks quite okay. And diagonal has a 3-me3 flow, and there's a diffuse disease in the diagonal in the mid-distal segment, so thought it's a good result. So we went ahead with the OCT imaging of the LAD.
So your distal dissection is covered, you have good apposition, very, very good apposition, actually.
Yeah, so stent looks reasonably well expanded. At some places, there was some eccentric expansion because of calcium.
Beautiful.
But looks reasonably well. And
Little bit of...
this is the snapshot of that, and it's looking quite good. At some places, you can see the red dots. That means a little malposition, but it was close to 50 microns. And this is the proximal LAD and OCT run. That was also
this is the post-dilation,
yeah. So because
you post-dilated with the same diameter that the OCT gave you, or you oversized? That's the question.
Same diameter, but at a higher pressure. Just because of the two red dots, we thought let go high pressures. And then we saw the large perforation, and patient had a severe chest pain, hemodynamic deterioration. Immediately, the pericardiocentesis was done and balloon tamponade. And following that, the one more groin axis, because its PCI is from right radial, it immediately took the right femoral axis. And with the balloon tamponade, one more guide, and then with the guide extension, they put the 3 into 19-meter graft master at the perforation site, and it got sealed off. And he got stabilized immediately.
The diagonal is protected, so very
the
nice.
diagonal is fine.
Very nice
Flowing
result.
well, yeah. So majority of rotablation cases are safe, and we rarely encounter the complication with a good volume. So one should be prepared to handle any complication while doing complex PCI. Complications are inevitable. Imaging does help in the complex lesions, but at times you tend to overdo it. Because it was a 50, 60 macron, not very...
That's like a strong statement you put there.
So just try to polish it and
inevitable.
one more dilatation, and we develop perforations, although it was already done case. So best is enemy of good, and be satisfied with the good result. Thank you very much.
Excellent case.